To get started. All right. I think I know most of the folks on here. I'm Joe. I'm one of the fellows out at Highland. I want to talk today about using stellate ganglion blocks for ventricular storm. So looking at refractory VT and VF, which is a little bit of a Wild West area when it comes to us doing this, but has some data in the ICU literature for patients that are like sitting up there and just going into VF like 10 times a day to use these blocks to try to reduce the burden. So the reason I got into this at all started with Trent's case report from this is like end of 2019, beginning of 2020. I remember like sitting around at the beginning of COVID when like none of us had anything to do and actually like picking up annals and reading it and thinking that this had to be like the single sexiest thing that's ever happened in emergency medicine. And so we'll just walk through that case. Some of you guys might be familiar with it. But essentially, he had a 65-year-old who came in, had a STEMI on an EMS EKG, and then right as they got to the ER and they were talking to him, become unresponsive, went into a VT arrest. So they started CPR, they defibrillated him like time after time after time, gave him epi multiple times, amio multiple times, got ROSC for like a hot second, and then he vomited, aspirated, and then went back into VF, got MAG, got bicarb. They were like starting esmolol and nothing was working. And then even went on to dual sequence defibrillation, which, at 2020, we didn't have all the data that we have now on it to say that it's probably actually a good idea. But even that wasn't working. And so they're basically at a point where this guy had been coding for about 40 minutes. Nothing had worked, was still sitting in VF. And so we're faced with the option of like, do we call the code? Or they decided to do a last ditch effort with a left stellate ganglion block with just 10 cc's of 1% Lido. And on their next round of CPR, they defibrillated again and got ROSC. And then somehow this guy managed to make it to his PCI, got a couple of stents in his LAD, and then a little over a month later was discharged from the hospital, like entirely neuro intact, which is amazing. I don't think any of us had like ever anticipated when you're 40 minutes into a VT arrest to have this person actually walk out of the hospital with nothing neurologically wrong with them. So I want to give just a little background on stellate ganglion, the anatomy, and the idea behind what we're doing. So stellate ganglion sits at the base of the cervical sympathetic chain. So it's like the highest thoracic sympathetic ganglion. And so sits just lateral to the vertebral bodies, and then just anterior to the transverse processes of the vertebrae. So this is it down at like C7T1. The reason we go after this is because the sympathetic output to the heart comes from the stellate ganglion to the cardiac plexus. And so if you've got a huge amount of sympathetic tone, we can knock this out and essentially provide like a pharmacologic cardiac sympathectomy. Now, there appears to be some variation between like the left and right-sided innervation. So we see like different responses depending on which side you block it on. On the left, it tends to give you bradycardia. On the right, it will control things like VT and VF, but it will be far more likely to make you hypotensive. And that's what they've seen in the literature when they look at this for other indications for people that are like getting this done in clinic by chronic pain services because of either their like complex regional pain or they're doing this for things like PTSD now. When we're looking at this on ultrasound, so this used to be all done by palpation, which is terrifying, right? Thinking of all the things that are in the neck. The reason you can do it by palpation is because C6 has a very prominent transverse process. This is the anterior tubercle of the C6 transverse process. And you can actually feel it if you press down on your neck. It'll be like just a little bit inferior to your like cricothyroid membrane and off to the side. There's a little bony prominence there. And they used to just palpate that, pull your carotid over to the side so you don't just stab straight through it, and they'd put the needle down on bone and dump anesthetic there. Clearly, a million things can go wrong with that. We now do this with ultrasound guidance, or sometimes the anesthesia pain people do it with fluoroscopy. So this is that anterior tubercle. Our approach would be coming from lateral, like posterior and lateral to medial, guiding your needle just over that tubercle and putting it on top of the longus colli muscle here, kind of in between that and the carotid. And your IJ right here is just flattened out because they're putting pressure on it. There's a video of what that looks like. So needle coming in, we're getting just down on top of the muscle here. And then as you inject, we'll see it separate out the carotid from that muscle. And then as they pull the needle back, you'll actually be able to see what's probably at this level, it's probably the inferior cervical ganglion floating in that anesthetic. The idea is that that will spread along the fascial plane, down a vertebral body or two, and knock out the stellate ganglion as well. When the anesthesia people are doing this for the patients that are up in the ICU having refractory ventricular arrhythmias, they're typically doing bupivacaine. I think in the context that we're talking about, where we're doing this for somebody that's actively in arrest, that it probably makes more sense to do lidocaine, especially because when they look at the data on how long the effect lasts for, it has very little to do with the duration of action of the local anesthetic itself. So the idea is more that you're like resetting that sympathetic ganglion rather than having like 72 hours of local anesthetic effect.
Hey, Joe, can I ask a question?
Yeah.
Just from this image, right? So it's from looking, I'm going to talk for yours, just looking at this view, there's obviously you're scanning up and down, but when you did this, I've done 2 of these and I've had a hard time with ensuring I'm not spearing the brachial plexus as I go through the middle scaling. Mm-hmm. And are you pre-scanning? Are you locating your brachial plexus and then sliding up to make sure it goes away? Because again, just from this view, I'm really worried that you're going to hit something or I'm going to hit something. Yeah.
So this is probably your inner scaling groove right here. So the couple of times that I've done this, what I've done is I put the carotid really in the middle of this, like very middle of the screen, so that I have a little bit steeper angle with my needle to try to avoid both the EJ that's floating out here as well as the brachial plexus. So and originally when they were doing this ultrasound guided, they were actually going like paratracheal still, which seems silly. That seems like a really great way to just make everything bleed.
Yeah, for me, whenever I've done this, again, I've always used, it sounds, even though I like the neck anatomy, I use the thyroid, I use the carotid, and I assume the IJ is going to be up lateral. And I put the needle in, and then when they stop, I just push real fast, get underneath the carotid, and then just push. That's how I've been doing it. Does anybody else have a better simplified technique? Because this is obviously, you don't want to pause too long, and you also don't want to hit anything that's obviously dangerous. Any ideas?
So I haven't been pausing.
Okay. Right when they're doing the compression pause, I put the needle in the neck. I go through. I have it ready. The minute they go, I slide it in. I push and then I pull out. That's how I've been doing it. You're not pausing at all.
I'm not pausing. If they've got the Lucas going instead of doing manual compressions, then typically there's not all that much movement up in the neck. So I've found it like not terribly difficult to try to get this done during compressions.
Anybody else?
Are you guys able to hear Arun in the background here? Yeah.
Any other ways to do this that makes it so it's not, because this can be challenging. I like the neck anatomy and I still feel a little challenged by doing this during codes. And I've only done it twice, so I've scanned a bunch of people just to get my landmarks. And during that time, I'm kind of a little bit shit scared. And so I feel like that's the anatomy I'm using. I'm using the tip of the thyroid, the carotid, and then sliding underneath.
Mm-hmm.
I'm not using, I know Gadsden goes over all this great anatomy, which I think is great, but I just don't get that great anatomy when I'm doing this quickly.
Yeah.
Okay.
I mean, I think the most important parts are you're going to find your carotid. Sure. And you're going to be able to see the muscle right underneath it. That's and as long as you split those apart, you're going to be good.
That's what I'm doing, right? I'm not using the landmarks. Okay.
Yeah.
I'm not. All
right. I'm just going to talk through like one study that is like the best available data on this. And we'll see that it's really not that great. Like the results that they've demonstrated seem pretty dramatic, but we don't have great quality data. So this is a study from Mayo back in 2019 that was a retrospective study of 30 patients that were in their ICU. Most of them were super, super sick. So on 2 to 3 antiarrhythmics, most of them on mechanical support, whether it was ECMO or balloon pumps or LVADs. And then they continued to have refractory ventricular arrhythmias and went on to have stellate ganglion blocks. And of those 30 patients, 60% of them didn't have any more ventricular arrhythmias after the block over the next 24 hours. And half of them sustained that through 72 hours. And when they looked at all the patients that had like ICDs implanted and they could see, how many episodes they were having, like in pretty granular detail, there was over 90% reduction pre versus post. If you were one of those patients that had a significant reduction or were arrhythmia free in the first 24 hours, you also had a significantly higher chance of surviving to hospital discharge. And while this is like a pretty small group and definitely not powered for finding evidence of complications, they didn't see any procedural complications in the study. The biggest problem with this is that we're just having all of these patients serve as their own control pre versus post, and it kind of assumes that nothing else changed over that time period when, a lot of these patients are probably MI patients that, their chance of arrhythmia is going to decline over time, regardless of what we do to them. But the results do look pretty promising. So then the question, so this is where I'm going to stop really talking that much about the block itself and open it up a little bit to see where people think that this should fit into our algorithm for these patients that are in refractory VTVF. How do you coordinate this with other medications and with dual sequential defibrillation? And like how far into the code are you waiting before you're going to pull something like this out? Because presumably, if we're gonna salvage these people and try to have them neuro intact, we'd want to deploy these kind of as rapidly as possible.
Can I ask a bigger question? Yeah. Because this is obviously the reason for these conversations is to be really upfront and honest. How many people at your site are regularly using dual sequence defibrillation? Any? I've been trying to use it just from that 2022 study, right? It wasn't powered correctly in the whole bit. You guys know the whole the OCVF. The New England Journal study. The New England Journal, yeah, whatever. But it wasn't powered correctly, but showed some benefit, right? Even though it wasn't a great study, that dual sequence defibrillation did much better. How many were using Esmolol?
So
I just want to know, because I think this is that same vein, right? Like, are we going to add new stuff? And if we are, then I think we should do it, right? Yeah. I just don't know how people are still even doing this.
Yeah.
Rune, I've run into, I feel like the vector change and then quickly going into dual sequential defibrillation, other than bringing a second device into the room, doesn't feel like that big of a departure. And the Esmolol was like a very easy ask from pharmacy. I think I haven't done a stellate ganglion block just because I think if I started approaching the patient with the Lucas on with a needle, I think people would come at me with a needle. So, so I have not done one of these yet, but I would say the other two are very easy to adopt in terms of like, where do we adjust the algorithm Whereas without more data on this, I don't know how to change our algorithm at least.
So that's I
This
think
is one of those things you can't get more data on, though. This is like as rare as a scenario as you find.
But what I mean is that we have some data, some utility of Esmolol and dual sequence fibrillation. I think that a lot of people don't even implement this. It's hard to ask them to implement this, to implement a block if they're not doing kind of stuff that has some data. I think that if I'm going down the route with somebody that I'm going to be like, I need dual sequential defibrillation, if you get the Esmol out, plot 50 or plot 30, whatever, right? 25 mg per kg. Then I'm getting my needle drawn up. That's how I think of it in my mind. So if I'm going down that route, I should have my needle ready. Go, right? Like, and that's, in my opinion, that's what should be done. I would love to hear other people's thoughts, because obviously, like Joe said, me pulling a needle out when I haven't done these two, maybe some data-driven stuff, it's really hard to convince other people to do this. Does that make sense to you guys?
Yeah. Yeah, the worry I have about having like a very long approach and saying like we're only going to do this as like an absolute salvage therapy. It's like I'm doing this or I'm calling the code.
I agree.
It's just that
we're not going to get any wins.
We'll be waiting so long on it that we're gonna lose any effect that we might have if we do it earlier.
I totally agree, but I mean, the hard part is I think a lot of people around the country don't even implement some of the data-driven stuff.
Yeah, in my mind, if the first defibrillation doesn't work, then I'm calling for epi, and I'm going to go ahead and start getting a second defibrillator in the room to set up for dual sequence. And then it'll be amio next, dual sequence next, Esmolol. Right. And then if we're still not getting anywhere, then
so that's how I'm playing the game. I think in my mind, right? I think it's like that. Like, when do you crank somebody, right? When they're dead is usually not a good time to crank them. When their OG stats 20%, but none of us want to crank somebody. But you have to think about cranking initially, have it ready with your scalpel in hand. Otherwise, you'll never crank somebody, right? I don't mean that in a bad way. So I think that thinking about this, the minute you're like, let's get double sequence defibrillation ready, you should have 10 cc of lidocaine pulled up. 22 gauge needle or 21 gauge needle and be like, okay, keep going, Esmolol, we're not going, boom. Yeah. I think that's how my mind has been working with this. I spent a lot of time, because initially I was like, this is a dumb idea. I'm going to do it on a dead patient. And I think that's the biggest flaw. But I don't know how to get it in the hands of people, because obviously I don't want my secondary resident to do this first before they've gone through other stuff that could be more evidence-based.
So I kind of like, I'm just more surprised that there's this many case series, I guess, looking in the ICU literature, but like from the ER standpoint, like I've only had one case that I wasn't even my own case, I was president, and we did this in where the patient actually died with defib as a rhythm. Like we could not get him out of defib. We don't have that point here either. So and it was like an hour of CPR. So I just don't think it's that common. For me, I usually have results with dual sequential or with lidocaine, with mag. Esmolol here is really tough too. That's not an easy drug to get. When we try to call for Esmolol, it has to come from pharmacy, so it's not a quick drug to get. So for me, it's really dual sequential. I'll do lidocaine, amio, of course, and then mag as like a last stage. But I haven't had, I mean, the fact that I haven't had my own personal case where I've called someone in VFib or VT as a rhythm. How many of you have actually had that be the final rhythm when you call a code?
So I had one last week where it like devolved into VT or into VF, refractory to multiple shocks. We did a stellate ganglion, and then it went PEA. We never got ROSC, but we at least changed the rhythm.
Like since I've been reading this literature, it's been a few years.
But they sound with VFib.
It's not common. It's uncommon. Even the dual sequence defibrillation is uncommon. It's an uncommon thing. But I think what I'm trying to get at is I think that there is I think this is maybe a good idea. It's hard to institute it when the other stuff that has maybe some more data people are not doing nationally.
Yeah, I think that just like Arun said, I mean, I think there's a lot of variety in where people kind of go down to the other interventions, with dual sequential, the fib, Esmolol. I kind of agree. Like if you're going down that pathway, like definitely start incorporating the stellate ganglion block. And I love this idea. We did one at Vanderbilt just a few months ago where they had an arrest and they did dual sequential, they did Esmolol, and they did the block, and they got ROSC. That being said, I think that between a lot of, I've polled some of my colleagues on this, and I think that there's, again, the difficult part about this is that there's a lot of variety at which each individual is jumping to those extra interventions versus just continuing with, high quality CPR and defibrillation. And so I think that's where it becomes pretty difficult to implement.
I think it has to be earlier and thought about in the same way that you have to think about pregnancy way earlier than with your hypoxic, right? Like this is that same. I think the more we as a group think about this and really have it in our brains, like, oh wow, this person's been persistent VTAC, VFib, we've shocked them, we've done some stuff. Get the pads out, get the Esmolol out, get my intensity lidocaine. I think that we will have higher saves.
Yeah,
I think.
Yeah, I do think that we have to be like really thoughtful about when we have these patients like running up the ladder of different interventions, right. Like not
one
sitting.
thing I would also be curious too is in hospital versus out of hospital arrests.
Yeah, I mean, Trent's was kind of out of hospital and in hospital, right? Was that right, Trent?
It was on arrival.
Yeah, sorry, I'm working clinically, but this is the best save I will ever have. I will never, in the rest of my career, have a better save.
That's awesome.
The guy had one of those, you know how when you go into VFib, it looks like a seizure? He had that death rattle in front of us, and then he was in VFib. And for 40 minutes, we threw everything we could at this guy. And the reason I knew about the stellate ganglion block is because my co-fellow, I was in fellowship at the time, literally mentioned that on ultrasound podcasts, they had just talked about the stellate ganglion block. So literally 1.5 weeks before I did this, I had watched the YouTube video from ultrasoundpodcast.com where they were going through it. And my co-author is the second to last author on this. He wasn't anywhere present. He just gave me the idea, and we went after it. I think you guys, Joe, you covered it you had a beautiful presentation. I'm sorry I was in and out for it because clinical work. My couple of thoughts. One, in terms of going through the brachial plexus, that C6 tubercle, the carotid tubercle, there's an eponym for it, but I forget it. But the C7 nerve root of your interscaling brachial plexus is going to dive into that tubercle. So if you're doing if you're looking at your brachial plexus at interscaling level, if you see the C7 root dive into that tubercle, you're at the right level. You go adjacent to that, longest colli muscle right on top of that, inject and lifting up the prevertebral fascia in the carotid artery. Remember, this patient's in cardiac arrest. If you fuck it up and that lidocaine goes intravascularly, you're like, oh, well, I guess this guy's in VFib, VTAC arrest. Might as well try it. Like, if you fuck it up, it's going to go intravascularly. Great. Hopefully that works too. Your patient, if you do it correctly, is going to get a Horner syndrome. So how we knew it worked was about an hour in, we got the cardiologist to come down because he still was alive an hour in. And the cardiologist was like, he has a blown pupil. Did you guys scan his head? And I was like, wait, that means it worked. Shit. And then if you do it, you're supposed to do it on the left stellate ganglion because that is the side that's a little bit more efficacious, a little less pro-arrhythmogenic. And when you block it, the whole goal is that you're increasing the threshold to arrhythmia. So when you perform the block, you still got to do ACLS, and hopefully on your next cycle, when you defib them, they are going to then be in PEA. When you converted that patient from defib to PEA, I count that as a win because that has happened to me. They then died, but they died in PEA. And so the case for this guy, he's still alive. I think for me and for us, this was like our last ditch resort. Now we talked about like when we were going to pull it out. I now have more of a thought about pulling out earlier in my VFib storm, refractory VFib VTACs. But he's so far the only guy who's walked out in the hospital. And I think that it's a really, really cool block because this is the essence of what emergency medicine is. Like, we were down to our very last intervention. We administered it to him. I thought he was going to have no neurologic status whatsoever. Apparently in CCU the next day, he was kind of waking up from his sedation. And he wrote on a notepad to his son. He wrote on a notepad saying, hey, where's mom? Is everybody okay? my car is parked at this exact address. Can you please move my car? Otherwise, it's going to get towed and I'm going to get ticketed. And at that point, his son knew everything was going to be okay. And so this block is the best. This block has led to the best save I've ever had. I still keep in touch with the guy. He texts me every time on his death day, which is February 1st. I have pictures with him. I went to his birthday party. I'm part of a big Staten Island Italian family now. And I think the idea of this block is so cool because of the fact that it might actually work. And I cannot believe it fucking worked and it saved a life. And I don't think I'll ever have a better save than this case report.
How many of these have you done, Trent?
I am 2 for 7. One was that guy that we actually saved. 2 went into PEA, sinus, then PEA, and then he died. And then the other 7 have just died. But for me, I pull this out. This is like the last thing because if you terminate a guy's sympathetic chain, they might not have a sympathetic nervous system, and that's part of the reason you're using lidocaine. If you use bupivacaine and they have no sympathetic nervous system for like 8 to 12 hours, that might come back to bite you when you have to increase their dose of pressors in their end. So lidocaine without epi, because epi promogenic is your anesthetic of choice.
But Trent, I think it's a great case, and I think it's amazing. I think what I was trying to get at was we should be thinking about this earlier and use it once you're down the road of shock refractory VFib or VTAC. I think that then this package, in your brain starts coming out. Like it should come out earlier. Dual sequence, Esmol, and this. And if we all would do that, if this is all kind of our standard operating procedure, I think we get more signal and less noise.
I think so too. I think we lucked out in a couple ways for this guy. First off, he arrested like as soon as he rolled in the door. I had like 3 people in the room doing CPR for literally 40 minutes while we were thinking. And for me, that idea was fresh in my mind. I was a fellow at the time. I had never done this nerve block before. I literally just YouTubed it like a week and a half ago. And before I did it, in the trauma bay, I pulled up the YouTube video from Ultrasound Podcast to watch what the fuck I was about to do. So that probably cost me a little bit of time on the back end. So now that I think it's great that we're talking about this because now that you have this in your arsenal, I think you will get to it a little bit earlier. Like it's the same thought as Esmolol to, block the sympathetic to try and terminate that sympathetic overdrive of your patient. So yeah, I think if I had this case again, I probably would do it earlier. But I'm not going to argue with the results of the case. This one worked out for me.
Trent, would you have that kind of case now? How early are you prepping the room for moving forward with that, right? Because I think that's like when I'm thinking about my shop, I already considered a win if I can get some of the providers to do an interscaling block, let alone like thinking about the same anatomy. And so I'm just like thinking forward of, do you do that pretty early?
I think when I'm getting to dual sequential and Esmolol, that's when I'm asking for 10 cc's of 1% lidocaine and a nerve block needle. That's around the time I do it. Because remember, you're going to be blocking the sympathetic chain. And so because of that, your patient could have hypotension for the next hour while you wait for your lidocaine to wear off. And so if you get ROS, you still have to initiate post-ROS care. And so that could come back to bite you in a little bit. So for me, I think about that as, okay, I'm going to accept the fact that my patient is going to be hypotensive with lack of a left-sided sympathetic nervous system or potentially a lack of a sympathetic nervous system, because if I don't break this arrhythmia, they're going to die.
So Trent, is this at like, second shock, third shock of refractory VT, or like when are you pulling out, all of the stops with dual sequential and Esmolol and then looking to start drawing up lidocaine?
Got it. That's a great question. I think it's dependent on how much like they've already had outpatient, like if they've already gone through like 20 minutes of ACLS with defibs. I think for me, like my workflow, I usually give them 3 like single defibrillations. Then if 3 don't work and they're still in VFib, that's when I'm starting to think, okay, I need the other Zol in the room. For us, fortunately, like we have like a resus bay of 6 beds, so like the Zols are pretty close by, so it doesn't take too long to get it set up. So, but I think Joe, you mentioned it earlier, it's very variable for everybody. Everyone's gonna have their own level of comfort with when to initiate this, and I think it's very case dependent.
So I just wanted to wonder whether or not there might be applicability to using this for atrial fibrillation with rapid ventricular response if you have like refractory, or and I mentioned this actually partly because I worked on the I run a fellowship in Latin America, and they don't have access to beta blockers or calcium channel blockade. They don't have the digoxin for treatment of AFib with RVR. That's like the only medicine they have available in a lot of the hospitals. And so my fellow asked me this question was like, hey, can we use a stellate ganglia? Because this person's been going at like whatever 188 with RVR now for 12 hours. The digoxin's not working. Can we do this? And so I just wanted to what the people would think about maybe applying this for that, or what are the considerations we should have if we're thinking about that. Hypotension, we just mentioned, right? If we use a long-acting agent,
I'm gonna say no, just because to me, atrial fibrillation with RVR is a rhythm that it's a storm in the atria, and you just need AV nodal blockade. I guess that probably may work, but I mean, really a dangerous thing to do when somebody gets hypotensive. That,
yeah,
my opinion.
Yeah, because you wouldn't be doing it unless the patient is crashing hypotensive, right? Because the risk profile is just high for somebody that's not dead already.
Yeah. I was going to say, I'm sorry. I had a discussion with our director of regional anesthesia, because our regional anesthesia team at Hartford, they do stellate ganglion blocks for VFib, VTAC, like refractory VFib, VTAC here. And I think we talked about it because I had the case report, and I think like we've gotten to an agreement that like if a patient's unstable or cardiac arrest, that's when we do it. But if you manage to reach some level of stability, our regional anesthesia team, they do this not infrequently for VTAC, VFib storm here. So that's something for them, like it's worked for them on the floor. So I don't see why it wouldn't work for us in the emergency departments, because I've actually seen regional anesthesia come down and do it once. They did, they were successful, and they it's not infrequent they do them. So
the last thing, we're like a little over time here, but the last thing I wanted to bring up was whether you guys have ideas for how we can actually generate some data on this, because we've had a few cases, right? Trent, you've done 7. I've done a couple. David, you've done 1. Like Arun's done a couple. These cases are out there, and if we're for all the sites that are in the block registry, it's like we should be capturing at least the times that we're doing it. But then how would you guys recommend actually going about studying it and putting together a data set? Thoughts?
I mean, I feel bad saying this. I kind of agree with Andrew, and he was like, this is a really difficult one to study because of the fact that our time of using it is at like midway or like towards the end of our cardiac arrest resuscitation, and there's just so many other variables that go on there. But I'm interested because I've done a couple of these now, and I'd love to pull data. So
I mean, Joe, sorry, I signed on late. I know there are case reports that we were talking about. Has there been a case series?
The only case series I think was 2 patients. So we haven't put together any of those out of emergency medicine. Yeah, the only case, they're like real case series, were done by anesthesia pain in the ICU setting.
Yeah, I mean, you could easily do like a multi-center case series from the registry. It's not great data, but at least it's the next step up from a case report in the ED, and then kind of slowly work your way up from there.
Yeah, I think the nerve block registry is the best way to go about, because we should, in theory, the ones we've done here should be categorized as other blocks or stellate ganglion as listed. I can look actually and see what we've done so far, actually, more than done.
Yeah.
And that's IRB approved already, right? So that way you can just have that be a retrospective review of color remaining.
Would we need we can talk about this offline, what all we would need IRB wise, but
for us it's already approved. Yeah. For other, I left IRB open for any sort of QA projects.
All right, well we're past time, so any other parting thoughts?
I just wanted to share one very last thing. If I could share my screen. let's see. Can you guys see that picture on my screen?
Yes, we can.
Awesome. Again, not to harp on this case, but the guy in the middle, his name is Joe. He is now 68. He's from Staten Island. This is me. My resident is on the left side of this picture. And I have full permission to share this picture because he's a hilarious dude with an excellent family. And I think that this case represents, again, what's so great about emergency medicine, the fact that like we in ultrasound are able to do all this kind of stuff. I urge you, like, if you guys haven't tried this block already, if you encounter a case of VFib, VTAC storm, please try it because it worked for me. And when it worked, it fucking worked. I got this guy out of the fucking hospital. I can't believe it worked, but it did. And I think I'm going to work another 20, 30 years in emergency medicine. I don't think I'm going to have a better save. So sorry to take your time over with that, but I love showing that picture because it's what we do, man.
Hopefully it happens again, Trent.
Totally worth it.
One more time.
Yeah. All right.
Yeah. I'm going to be like 0 for 10 for the next blocks, but hey, it was worth it that one time.
All right.
Pay attention to your co-fellas too. They tell you important shit and then you try it.
All right. Awesome. Thanks, guys.
Fantastic.
Thanks, Joe.
I had a quick question. I don't know if
We'll see you in
Andy's. See you then. If Andy's still on the call, Andrew Goldsmith. So, do we know in the registry if we're capturing any data specific to this block in the registry?
You can enter it in, but we should add like a separate like line.
Okay.
Because I mean, I don't know how many are done, but it's got to be less than 10.
Right. But I mean, you could easily draw lots of, this case series that we're kind of imagining. That's probably where the data is going to come from.
Let me add it into the red cap, and then on their next meeting, we can download the new red cap with that.
Cool.
Yeah, Andrew, I'll chat with you offline about like what to include for outcome for it. All right.
All right. Sounds good, man.
Have a great one, guys.